Thank you. It's really a pleasure to be here, and I apologize for my voice, which is a little hoarse from a bit of traveling recently. I actually am in town because the Medical Decision Making Conference, Society for Medical Decision Making Conference, is just wrapping up today in Vancouver, and that is, in fact, the society that Dr. Nozick and I are both members of, and that's where we met in a conference in Toronto. There we have a North American meeting with a very strong Canadian contingent every year. Every other year we have a meeting in Europe as well. So I encourage you to look into that society, and we have a very vibrant poster session every year, which was very useful. So I'm going to just show my financial disclosures. As Badan mentioned, our center is funded by the National Institute on Drug Abuse, and the research that I'm going to be presenting here is funded by that center, a grant, as well as several other grants from NIDA and some additional funding from NIAID, all part of NIH. I have no other financial disclosures. Just a little bit about CHERISH. There are some handouts by the sodas. Please take copies of our newsletter and a couple of cards as well about some of the services that we offer. We've been in existence for about a year, just over a year. We are funded to develop, disseminate health economic research on healthcare utilization, health outcomes, and health-related behaviors that inform substance use disorder treatment policy and HCV and HIV care of substance users. And we are particularly focusing in the US on increasing the impact of this research that address integrated healthcare system providers and payers, because in the US healthcare system, and from what I'm learning from Badan, this is also affecting at least some of the provinces in Canada. There's an effort to integrate substance use disorder treatment and medical treatment and behavioral health treatment, and move away from some of the silos that have existed in the past. And we think that is an opportunity to re-engage decision makers about thinking more broadly about health economic impacts rather than just thinking about their silos, and that's what we think that we as health services researchers and health economists can bring to the party. We have a variety of audiences that we're trying to address and work with, including substance use disorder researchers, HIV and HCV researchers, such as many of you here in the room, health services researchers, health economists, people who are doing clinical trials, and people who work with health system research, health system data, who are actually, I mean, you are very fortunate here in Canada that you have integrated data systems that give you a lot of clinical detail of information about your populations. We have a lot more limitations in the US, but we are doing better with electronic health records, and we're trying to work with people who have those data to delve in and integrate that into health economic analysis. And we're trying to get all these people to talk to one another, people who are interested in the research but don't really have the health economic skills, people who have the health economic skills but really haven't worked with people with clinical research skills, and clinical trialists. Very importantly, a lot of my work has been, as you'll see a couple of examples, has been working with people who do clinical trials, not necessarily just clinical trials of pharmaceutical interventions, but also clinical trials of service interventions to add a health economic component to those clinical trial analyses. And then we're trying to reach out to the broader policy community, the treatment providers and payers, the policymakers at the federal and state levels, and the patient advocates, so that our research is actually responding to the questions that they want to ask. And a lot of times we as researchers think we know what the interesting questions are for us, but they may not actually be responding to the questions that are most important to policymakers. So that's what we're trying to do. As Dr. Nozick mentioned, we have 4 institutions that are part of our center. The administrative core is based at Weill Cornell. At Boston Medical Center is where our HIV and hepatitis C core is based, and that's where the clinical experts in those areas are, as well as the disease modelers. At Penn LDI, the Leonard Davis Institute of Health Economics at the University of Pennsylvania has a lot of expertise in dissemination of health economic policy to decision makers, and so we're leveraging that and their expertise to really reach out to decision makers to understand what are the questions that they want answered, and also to help people who produced research to translate their research into terms that decision makers understand. So that's been great. And then I'm working with Catherine McAllister at the University of Miami, who's a health economics researcher who's worked a lot in the substance use field, and together we are leading a methodology core. One of the important things that we're doing in the methodology area that I want to make you all aware of, and we have some cards, or you can come to this website or to our main website, is that we offer free methodology consultations of up to 6 hours, and that's open to researchers outside of our institution. So you can come to our website, log on and request a methodology consultation in these areas. And so if you're a researcher who's thinking of adding a health economic aspect to your research, if you're somebody who's thinking about submitting a grant application, particularly if you're thinking about submitting a grant application to a US funder like the NIH, we have experience in the area. We can help guide you in terms of thinking about those research questions. Or if you have some health economics expertise and you're trying to refine your questions, or in some cases we've helped people who got to revise and resubmit on a paper and they're sort of wrestling through how to respond to that, we can help do that. Now, you have a lot of expertise here locally with Dr. Nosik and his group, and you should take advantage of that, but we are another resource that's available as well. So do you think about taking advantage of that as well? Because we're there and we're funded to help. Okay, so that was my advertisement for CHERISH, and if you have further questions, I'm here to talk about that after the talk. So what I'm going to talk about is the rationale for HCV and HIV testing and linkage to care services in substance use disorder treatment settings. And then I'm going to talk about 2 specific trials and the cost effectiveness analyses that we've been doing alongside those trials, or with those trial results, using those trial results. One was focused on testing in substance use disorder treatment settings. These are all in the US. And the other was focused on a linkage to care intervention. And then if we have a moment at the end, I have one slide to talk about where we're going from here as we move out of the cost effectiveness results and into the implementation world, and where the rubber kind of meets the road. So as background, these are the cascades of care. I think those of you in the HIV field are very familiar with this issue of cascades of care, and Dr. Nosik has done a lot of work on the cascades of care in this province, and so you know the numbers here better than I do. These are the US cascades of care. You can see in let's see if I can get this to work, but in the US, this is the total number, estimated number, and there's debates about whether this number is too low, of chronically infected people with HCV. Most of these people were infected due to exposure to injection drugs, although not all of them. And only about half of those people are diagnosed and aware of their diagnosis of chronic HCV infection. So there's a huge gap here. And obviously people who are attending substance use treatment have a higher probability of being HCV infected and unaware of their status. So there's a big opportunity for testing, but also then linkage to care, because of those diagnosed, very few went through a confirmatory test. Only about half of them had a confirmatory test. And right now, very few have been treated, but that's because the new treatments have just become available and they're still quite expensive. On the other hand, in the US, we're doing much better in terms of awareness of an HIV diagnosis, but there's still a gap. And that gap, that some 14% gap in terms of awareness, those are the toughest to reach people. And we know the toughest to reach people are the people who are less likely to be engaged in medical care, but they may come through the substance use treatment setting at some point, particularly those who are actively using. And so that may be an opportunity to catch them. There's not going to be a lot of them, but the ones that you're going to catch are the ones who've sort of fallen through the cracks. And then there's still a big gap in terms of engagement and care, so that's the linkage opportunity. You may have someone in your substance use treatment program who knows that they're HIV positive, has been told they're HIV positive, but they're not engaged in care. And we actually are doing a lot better this in some jurisdictions. In New York, our numbers are much higher. In New York City and San Francisco, they're much higher, but it's quite variable across the country. And one of the things about substance use treatment programs is they're distributed across the country, and we may have the opportunity to address some of these disparities by focusing on substance use treatment programs, particularly in areas of the country where we're not doing too well. So the other focus is there's a new epidemic of new infections of HIV and hepatitis C, new outbreaks. So we just looked up and there were 180, I think, new HIV infections in Scott County, Indiana, a couple of years ago. And this was all directly related to injection drug use. And this was in a town of 5,000 people. So it was incredible. And the HCV infections in that area were even, of course, much higher. So this really raised the awareness of what we've been seeing really across the country. And I know in certain parts of Canada you're seeing this now as well. And we're seeing it also in terms of overdoses. That's sort of the other canary in the coal mine, if you will, in terms of infectious disease outbreaks. This incredible new wave of injection drug overdoses and injection drug transmission of infectious diseases. So this was in the Wall Street Journal. The article actually still, I checked online, still has not been published by the CDC. It's probably still sitting in clearance somewhere. But they have identified 220 counties that look like this Scott County in Indiana, based on some other demographic characteristics and overdose rates that are likely to be at risk for similar outbreaks. And so, and this was, this is based on older data. Now with fentanyl as the new drug of high risk, I think, there's probably more counties as well. So obviously some of these people do end up in treatment where treatment is made available. And there's a new awareness and hopefully new funding for making more OAT treatment, opiate agonist treatment programs available. And so that then becomes a new opportunity to identify people early, soon after they've been affected. And that's really important because we now have curative therapy available. This is a huge change in the hepatitis C world from a situation where interferon therapy was long, difficult, and had cure rates at best, in the real world of maybe 50%. Now, the regimens do have some varied efficacy depending on these characteristics. I was having this discussion with Dr. Linus, who heads the HCV HIV core in Boston Medical Center. And it's like, can I cross these off because there are now these pan-genotypic regimens that work across all genotypes? He said, well, there's still some variation depending on which genotype it is, what your treatment history is, whether you have cirrhosis or not, what your HCV RNA level is. But the variation is around whether the cure, this is a cure, is between 90 and 99% probability, right? That's huge. That's like, amazing that any cure could be between 90 and 99%, and we're sort of now worrying about, well, is it 95? Is it 94? Is it 98? That's just an amazing thing versus a couple of years ago. Now, obviously, there's major issues around cost and access to these medications. But the point is, if you find someone early, and particularly if you find an active injection drug user early, you have the ability to not only cure that person, prevent their disease progression, but potentially affect transmission. And there's still some questions about how much you're going to affect transmission, because that depends on whether you're pairing that with other measures to prevent them from using unclean needles. On the HIV side, we all know the story, 96% reduction in transmission to HIV uninfected partners. Here, in terms of the sexual transmission, the benefits are well known, much of it from the work coming from here. Starting early, there's a clear life expectancy benefit for the patient. So testing and linkage to care early, big benefit, right? U.S. Preventive Task Force has acknowledged that, and the reason why I indicated the grade A and B recommendations is because under Obamacare, we still have Obamacare. It has not been, the Congress has not gotten rid of Obamacare. And one of the other side benefits of Obamacare, there's a lot of pieces of Obamacare that people don't talk about. One of them was that if a recommendation has an A or B rating from the U.S. Preventive Service Task Force, it has to be covered, and it has to be covered without any copay by the patient. So this is important because one of the things that's been happening in the U.S. is copays and deductibles have been increasing. The amount that the patient has to pay for their care has been increasing. That's one of the ways that we've been trying to, I guess we as a country have been trying to control healthcare costs, but for the things that are important for preventative care, Obamacare says no, that has to be provided as part of insurance. So HCV and HIV testing are part of that, and includes not only high-risk adults, but actually, in the case of HCV, anyone in that birth cohort. So you don't have to have a long discussion with someone about what their risk behavior was about if they fall into that birth cohort. Just go ahead and test them. So it's obvious that people who are in substance use treatment are at higher risk, and testing will get them into care earlier. Getting them into care earlier will be a good thing in terms of their health. It's recommended. So we should do it, right? But we're not. So the evidence in the US is that we're not doing it very much, and actually we're doing it less than we used to. CTN is a National Institute on Drug Abuse network of sites that are in the community, which is where NIDA funds community-based randomized trials. And one of the 2 trials that I'm going to talk about was done in this network. And this is a little old. It was from 2006, but at that time only a third of the programs were offering HCV testing, and fewer half were offering HIV testing on-site, and on-site or through referral. And we'll talk about how the difference between offering on-site and referral, as you can imagine, on-site is much more likely to have the person actually get tested. And then among opioid agonist treatment programs, so primarily methadone maintenance treatment programs, HIV testing appears to be declining, particularly in for-profit programs. And let me just make a comment here about these types of programs. In the US, and this is particularly relevant for the second study that we did, methadone maintenance treatment programs are a particular unique kind of program. So methadone is not provided in pharmacies. You cannot go to a pharmacy and pick up methadone. You cannot have a physician write a prescription for methadone. You can for buprenorphine if the physician has a particular license to do that, and you can pick it up at a pharmacy, but not methadone. So the only way you can get methadone is you have to go to a federally approved methadone maintenance program. There's a lot of stigma around going to those programs, and most people, when they start, have to go daily. And so it creates a lot of limitations on people's lives, on their movement, and it's not a very fun thing to do. So it's a very constrained sort of treatment, and it's not available in many states, and in many states it's available only in a few places, and people have to travel very far to do it. So it's not a very easy access kind of program, which is why buprenorphine treatment in the US is a very important alternative access for opiate agonist treatment. We also saw that HCV testing on-site declined among all outpatient treatment programs more recently. And there's limited evidence on when the programs are doing testing, how well they're linking people to care. Because obviously if you test and you don't link, what's the point? So there are some successful programs. There was a review article that was done just recently in 2015. There's some successful examples, but there's really limited evidence. So here's the preview if you kind of doze off, or once you've had your lunch, it's a little postprandial. So HCV and HIV testing in substance use treatment programs does represent good value for money. So if we're going to start promoting this, we think there's a gap, there's a lesion here, and we should be promoting this policy, right? But is it good value for money? As health economists, we want to know before we start promoting this, is it good value for money? And then obviously if you test but you don't link to care, that's going to waste money. So we wanted to look at not just the testing, but the linkage to care. Cost effectiveness is the first step, but cost effectiveness is not the cost saving. And if there's one thing you want to learn from this lecture, the only thing you need to learn is that cost effectiveness is not cost saving. And so it's good value for money, but somebody's still going to have to pay for it. And so if somebody's still going to have to pay for it, the next step is we have to think about the budget impact. Who's going to pay for it, and how do we address that when we get out to implementation? And so that's the next step for our research. But we really feel that you can't just jump into, okay, how are we going to get this paid for, unless we make sure that the investment passes that threshold that it's good value for money. That's the way we kind of go about our economic analysis. Okay, so the first trial that was done in the CTN, in the NIDA CTN, was this trial led by Dr. Metch, which was looking at just HIV testing in substance abuse treatment programs broadly. So it was not just methadone maintenance programs. It was a wide selection of programs that were offering different kinds of treatment. Some were offering opiate agonist treatment, many were not. The typical treatment program in the U.S. does not offer, medication-assisted treatment. It's more of a counseling, often group counseling-oriented program. And these programs were not just treating opioid use disorder. They were treating all kinds of substance use disorder. Some of them were also treating alcohol use disorder, but they had to be treating substance uses other than alcohol in order to be participating in this trial. But a lot of the clients are recommended to the program or required to go to the program because of their involvement in the criminal justice system or family court, things like that. They had two research questions. What was the most effective strategy to increase the receipt of test results, which is on-site versus off-site? You can imagine on-site's going to be better, but how much better, right? And then the second was to decrease sexual risk behaviors, because the standard that had been promoted by the CDC for many years was that you had to do risk reduction counseling. So if you're doing on-site, you do the rapid test and then you provide risk reduction counseling as part of doing that test to anyone, not just the people who test positive, but to everyone, to think about what their risk behaviors are. And there's a standard way of doing that risk reduction counseling. But that is expensive because it takes more time of the counselor, and you have to train the counselor to do that risk reduction counseling. Whereas if you're implementing this in a substance use treatment program where the counselors are not necessarily providing that type of counseling, they're counseling, the person who's doing that testing may be a counselor, they may be a different staff member, and their focus is not necessarily on sexual risk reduction. It's a very manualized intervention to do it most effectively, because we wanted to do it as effectively as possible following the CDC recommended guidelines. So was it worth that extra cost to do what was the recommended standard? Because it really hadn't been examined in many years. And now in the current era, people get a lot of messages about sexual risk behavior reduction in the world. HIV is much more known than when the original studies were done. So they wanted to look at, so these are the sites. They were pretty well spread across the country. And as I said, there were a variety of different types of substance use treatment programs. The entry criteria, there were over almost 1,300 individuals enrolled. They had to be unaware of their HIV status or believe they were HIV negative, but not had a test within the last 12 months. They were about 40 years old, 61% male, significant percentage were non-white, significant percentage, about half had ever used injection drug use. A lot of them had previously been tested for HCV, which was interesting. So we didn't do HCV testing in this trial because a rapid HCV test was not approved at the time. So this was only HIV testing, and a goodly proportions reported that they knew they were HCV positive. So these are the results, and the first column is about how much better is it to do on-site than off-site. So clearly on-site referral, about 18% reported that they accepted the test and they knew the results. So what happened was we went back to them and asked them, do you remember being tested and do you remember your result? So it wasn't just from the lab result. We actually asked the patient, do you remember? Which is a tougher question, because they could have had the test and it never really registered with them. The 18% is probably a bit high, and that's for off-site, and that's because in the residential programs, they actually provided them transportation to the off-site location to get the test, which would not necessarily happen in practice. So they kind of bent over backwards to make that as accessible as possible. 85% basically accepted and remembered what the result was for the on-site. A little bit less for those who got counseling. It's not statistically significant difference. It may be because once they started the counseling, they were like, no, forget it. I'm not going to stay with this. I'm going out for a cigarette. Importantly, the number of unprotected sex acts, which is the self-report, but was the efficacy of the counseling intervention, no difference. So in this era, that extra money spent on doing the counseling really did not have an effect. And this is self-report, but we repeated this in a separate trial in STD clinics where we actually then got actual lab results in terms of STD incidence, which is a proxy. Study wasn't powered enough to have HIV incidence, but STD incidence, and it reinforced the same result. There was no difference in STD incidence between the people who got that counseling versus not. Now, this is a 20-minute short-term one-time counseling, so one could say there's just not enough dose there, but that was the standard recommendation in terms of what the CDC was recommending at the time. And as a result, CDC has now backed away from recommending that as having to be part of what is required for rapid testing, which is, I think, from a health economics perspective, great, because it means that it removes a barrier in terms of cost of doing on-site rapid HIV testing. Okay, so we do the cost effectiveness results. I won't go through the details because it's kind of pretty obvious, right? If it's more, if it doesn't affect the outcomes in terms of HIV risk, and you have more people being tested, then it's probably going to be cost effective because the added cost of just doing the on-site testing plus information was not that high. So we calculated the extra dollars it cost to basically train and do that on-site rapid testing, and it was sufficiently low that this was cost effective under a cost per quality threshold. I'll talk about what that threshold is in the next analysis, but just, in interest of time, I'm going to tell you that this was a cost-effective intervention according to the thresholds that we use in the US. Now, that's not to say that there aren't a lot of implementation barriers in getting this accepted and rolled out, and that's something that we're looking at now, but it met the societal threshold because you can see the gap is huge. And the value of identifying someone early, remember, I said if someone enters HIV care early, they can get up to 2 years benefit in terms of added life expectancy and that's a big bang for your buck. You don't need to find very many people. Even if you're testing a lot of people and you only find one or two, that one or two get 2 years of life expectancy benefit. It's worth spending a lot of money to do that. Okay, but as I said, cost effective is not cost saving. Cost effectiveness is about comparative assessment of worth. Very few interventions are cost saving. It's evaluated from a societal or health system perspective, and it does not address budget impact. It also doesn't address a whole lot of other important aspects, like what the clinical duty is when the patient is in front of you, ethical duties and equity issues. So sometimes we spend more money than on certain populations than other populations because we feel that they're disadvantaged or we need to reach out to them. So my example is a rural population. So sometimes we spend a lot more to deliver a service to a rural population than an urban population for the same service. And we're willing to do that. We're willing to spend more, essentially, to get the same quality adjusted life year, or the same improvement in life expectancy for that person who's living farther away. And therefore, it costs more to deliver the service because the clinic has one doctor serving fewer people and is less productive, if you will. But we believe it's worth that, right? So we essentially have a different threshold for that. And we think that that's fair, that's equitable. So there's not just one threshold, there's not just one level of cost per quality adjusted life year that we use for everyone, because we have other criteria as well. There's also patient preference. More and more, there's an effort, and I think that's also coming into play in Canada as we think about different thresholds of thinking about what does the patient want and what are the criteria that are important to the patient, because it may not be just, the quality may not capture some of the patient preferences. Sometimes patients have a particular time horizon that's very important to them. They want to live a certain number of years because they want to see their child graduate from school or get married, or they may have a particular preference for avoiding a particular side effect that's not really weighted in the qualities in the same way, because we're looking at qualities from a societal perspective. So there are alternative ways to look at making decisions and prioritizing beyond just economic efficiency, which is what I'm going to talk about here. And then there's the issue of affordability, which is the budget impact. So this is just saying hepatitis C has been a sort of a poster child in the US for this issue of budget impact. And in particular, our state Medicaid programs, which is the programs that fund care for people of low income and vary by state in terms of their financial health, how much the state contributes compared to the federal government, whether the state has decided to add under Obamacare, whether they've decided to expand to cover more people or not. That was an option. Some states chose it, some states didn't. And so different states have made different decisions about whether to cover the new hepatitis C drugs or not with different limitations. And there are now lawsuits in several states questioning those limits because whether those are consistent with federal guidelines or not. So, given all this sort of, that was my little, cost effectiveness in 3 slides, right? But at the end of the day, we end up with a cost effectiveness ratio, which is the additional cost for one additional quality adjusted life year. In the U.S., we generally have, there used to be this ratio of $50,000 per quality adjusted life year that you saw in the literature a lot. In the U.S., it really has evolved to $100,000 per quality adjusted life year because we look at what we're actually spending on these days, and it's in that range. Some people argue for $150,000. Some people still look at the old $50,000 number, so often we look at that range. In Canada, is there a generally accepted number? 60, 70?
I usually go with the WHO criteria, which ties the threshold
to the GDP, 3 times GDP?
Right, it's still not perfect.
Right.
At least it
and what's GDP in Canada?
To pay.
And what's GDP in Canada? So in the U.S., the 30,
40,
40,
50,000.
okay, so it would be similar. So in the U.S., the 100,000 threshold is about 3 times GDP. So a little, maybe it would be a little higher. So it's more or less similar. 1 times GDP would be considered really cost effective. 3 times GDP would be considered cost effective. So that's sort of the cost effectiveness tutorial piece. So the FDA approved the HCV rapid test, but it was after the trial. So we went back and used the trial data, and we had published, the cost effectiveness results of the HIV testing. But we were really interested because this was approved and because, as you saw, there was such a high number of people who knew they were HCV positive, so they're in that group. So we suspected there was another large number of people who didn't know they were HCV positive in those 1,300 patients, right? Because we saw that the proportion of people who know they're HCV positive is 50%, right, in the cascade. And it's probably, so clearly HCV testing, or we believe that HCV testing in substance use treatment programs is going to be also of interest. And the other thing is that the rate of HCV positives is going to be much higher than the rate of HIV positives. And one interesting thing, I'd be interested to see those of you who work in the field, we thought it might be more motivating to people who are in the programs if they actually had people who tested positive and were doing something about it. Because most programs had very few HIV positives, if any, because the prevalence is just very low compared to HCV. So they're doing a lot of testing, but most of their tests are negative. Whereas if they're doing HCV and HIV testing, they're going to have a lot of HCV positive people. And that's sort of, okay, now I can do something. I've got some positive tests. That's a motivating thing to keep the program going. So this was published in Addiction. So this is a modeling study, but it's based on the results of the trial. So we came up with these testing strategies, no intervention, which means not that there's never going to be any testing. We believe there's testing going on in the community. Remember, there were people out there who knew they were positive. We came up with some assumptions about what the testing rates for HIV and hepatitis C are in the community. And in the previous study, we had an assumption about HIV testing in the community. And that was based on what people told us at baseline in the trial about when they were last tested. So we used that information to come up with assumptions about, in this population, what's the background rate of testing. And we were pretty aggressive about that because this is a population that does have exposure to testing elsewhere, particularly in the criminal justice system. In the US, HIV, not so much Hep-C, but they do get HIV tested in the criminal justice system. And then referral for offsite for HCV testing. We already know that referral for offsite for HIV testing is a non-starter, but HCV testing, we wanted to still to look at that. On-site just doing the rapid HCV test, and then on-site doing both, because, we used, oh, sorry, I guess I repeated that slide. So then we used a mathematical model to estimate effectiveness and cost effectiveness. And we actually have two models, two pieces to the model. One is a screening model, which is basically a decision tree where we're looking at, which I'll show you a schematic of in a minute, where we're looking at basically, are they tested, do they accept the test or not, do they receive the results or not, and do they link to care or not, under the different scenarios. And the other is a mathematical simulation model of HCV disease that also includes co-infection or not, that simulates what happens to people if they are or not tested for the rest of their lives. Okay? And that's based at Boston Medical Center. So remember, all models are wrong, some models are useful. So these are useful models. They have some assumptions in them. This is the screening model. You can't really see it, but you can see essentially the four arms coming off of this first line are, oh, I can do this for this. No intervention, the offsite referral, the onsite rapid HCV only, and then the dual testing. And then this is just whether they accept, they return for the results, because remember, if they're offsite, they have to come back to get the results. It's not a rapid test offsite, it's a blood draw. That's just typically what happens if you go to health department. Their health departments generally don't do the rapid test right now. Then whether they link to care, and then whether they, when they link to care, that's a HCV RNA test, and that is also a test that is a blood draw, so you have to come back and get the results. So there's drop-off all along the way. For each of those scenarios, for each of those people at the end of those branches, whether they're aware or unaware, and then there's a question of what happens to them going down the road, and that's our simulation model, which has characteristics in terms of age, sex, HCV genotype, age of infection. All that comes from assumptions about the population that's in drug treatment, and then it simulates their disease progression, whether they're treated immediately or whether they're treated down the road because they were detected later. Mortality, morbidity, HIV co-infection, and importantly, mortality unrelated to HCV disease, which is going to be different for this population than for the general population in the US, because they are obviously at a higher risk for other kinds of mortality, including overdose. And then whether they were detected in the future, linked to care in the future. And we also looked at potential reinfection, which is people worry about a lot. We assume that the trial provided reasonable base case estimates. So if you accept an HIV test, we assume that you would accept an HCV test with at a similar rate. That's a pretty big, it's a big assumption, but I don't think that it's a completely heroic assumption. I think people's openness to accepting tests it may be pretty similar, and we'll see, hopefully in future trials we'll learn more about that. That people would accept a test with information only, they wouldn't need additional counseling. That if you're tested for HCV and you actually link to care, you will get an HIV test because that's part of the workup for HCV testing. So if you're co-infected, you'll eventually, and you actually link to care, someone will figure that out. And that clients accept both HCV and HIV testing as a package when it's offered. They don't sort of pick and choose. Those were kind of simplifying assumptions. So these are some of the inputs. I basically just to show that we had some inputs on a prevalence, on acceptance, which came from the trial. These numbers look different than the numbers I showed you before because these were the numbers only for the people who didn't know their HCV status. So we took a subgroup from the trial for the people who didn't know their HCV status. The linkage to care information, again, comes from that subgroup, and then some cost information. And so it costs about $3 just to screen someone on site and give them the information about linkage, but then they have to go and get linked. And then the cost of the on-site test offer, it's more expensive, obviously, to do 2 tests than 1. So our results, the referral off-site was less efficient. It just was obviously, it was just not a good use of resources, similar to what we saw in HIV. Rapid on-site testing, HCV only, had a good very attractive cost effectiveness ratio of 18,300 per quality adjusted life year. And then if you looked incrementally at doing the 2 versus 1, even though you're going to get very few HIV positive results when you do the 2, mostly you're going to get the HCV positive results, it still had an attractive cost effectiveness ratio using the 100,000 threshold, not the 50,000 threshold. But we believe the 100,000 threshold is the appropriate one. So we are in favor of doing both. In sensitivity analysis, on-site testing was always better than off-site testing. Even when we assumed a very low prevalence of HCV, it still was attractive as long as at least 20% of the HCV infected people were linked. So again, if you don't link, don't bother doing it. In on-site, the dual testing was still attractive even when HIV prevalence was very low, unless we assume that basically these people are being HIV tested a lot elsewhere. Results were consistent even when we looked at a range of cost assumptions, because at the time that we did this analysis, the new HCV drugs were still just coming out, so we didn't really know what the costs and efficacies were. Okay, so the limitations are HCV testing and receipt of results is based on the HIV results. We didn't do a new trial. We didn't look at the benefits from transmission, so that would make things look somewhat better. Probably not have a big impact because the results are so far down the road that they don't affect the cost effectiveness ratios that much. We were pretty conservative. We assume most of the HCV infected individuals did not initiate treatment because of the barriers that still existed in terms of access. And those barriers hopefully are changing. But we did assume that most HIV infected individuals do initiate treatment because there are fewer barriers and there's a lot of programs to improve accessibility in the US. There's all these implementation challenges that I talked about, startup costs, personnel to provide supervision and training, resources to improve linkage to care. Those are costs that are not baked into our costs because they're really costs of starting up the program and getting it running. And we didn't do a budget impact analysis. We conclude that on-site rapid HCV testing has a cost effectiveness ratio less than 50,000, assuming imperfect linkage to care and treatment acceptance. Referral to off-site testing is less efficient, and then doing the dual strategy is has a good value as a public health investment. Okay, so I'm now going to go on to the second trial. So this is linkage to care. So this trial was done in methadone maintenance programs, so the specialized programs that I talked about. So these programs are even further enriched for people who are Hep-C positive. So these are really programs where there's a lot of Hep-C positive people, but they haven't really been linked to Hep-C care. And now we're entering this new era of effective Hep-C treatment. And so how do we get these people who are not necessarily the ones that the hepatologists are running out trying to treat, how do we get them effectively linked to care? And they may even be located, in both of these programs, they were located in methadone maintenance programs that were on campuses of hospitals, but they weren't in the same building necessarily, right? Or even if they're the same building, they were down the hall, right? And there's a lot of cultural issues about moving from one place to another. So this trial was a broader trial because it was looking at hepatitis care coordination broadly. It was an open label trial, it was 2 arms, and they were actually looking at 2 outcomes, one having to do with hepatitis A and B vaccination, which is also really important for substance users. You probably know that better than I do, particularly the clinicians. And then the other was getting an initial appointment with a hepatitis C healthcare provider for the people who are Hep-C positive. So we focused on the second outcome, and we're looking at the cost effectiveness of the intervention as it relates to the second outcome. So there were 2 sites, one Beth Israel Hospital in New York City and one University of California, San Francisco. So maybe less broadly representative. These are academic medical centers, well-resourced. The trial population, there were about 500 people in the trial. You can see they're a little older, a little more male, a little more non-white, but somewhat similar to the other group. So here's the results for the 286 people who were Hep-C positive and therefore eligible for the linkage to care. You can see that For the mono-infected people, the intervention had a really big effect. They went from 34 in the control who just got screening and education to 68% for those who got care coordination. It had some effect for the co-infected people as well, but less so. And we believe that's because people who are HIV infected in those two communities have a lot of other resources that they can draw on. They have care managers, they have other, their HIV clinical care provides them a lot of other resources. So someone else will may be picking up the ball. So that there was a difference there that may not be generalizable elsewhere in the US. So we looked at these 4 strategies: no intervention, the control, and then we looked at just doing the intervention for the HCV positive since there was less effect for the HIV positive, and then we looked at doing it for all. And we used the same modeling approach, so the screening model and then the HEP-CE model. So we had a bunch of estimates, again, prevalence, background HCV testing rate and HIV testing rate. We didn't assume that this was the only shot. We assumed that if they didn't get this intervention, they would have the opportunity to be tested elsewhere. And then you can see the costs are a lot higher than the testing costs because this is actually providing, even in the control condition, they're getting screened, they're getting education. They're not just being left alone. But the intervention, obviously, they're getting a care coordination for 6 months. So there's an actual set of interactions with a care coordinator. So in our base case, the control condition either alone or the control condition, either the control condition for everyone or the control condition for the HIV infected people and the mono-infected people getting care coordination, those were both less efficient strategies. Providing the care coordination for everyone, including the HIV infected people, was the most attractive strategy. So again, even though the difference was less for the HIV infected people, co-infected people, even that small difference was still worth doing. So our conclusion was you should just do it for everyone. Don't sort of separate out who's HIV infected and who's not. And our preliminary results says that the cost effectiveness ratio is about 25,000 per quality, so worth doing. We're still doing sensitivity analysis, but so far we think that even if the interventions provide small improvements in linkage rates, it's attractive, and that even intervention costs are higher than what we estimated, it's still attractive, although at some point, if the intervention is really expensive, then you would not do it for the HIV infected folks. And then we looked at reinfection because a lot of policymakers are saying, why are you treating these people? They're just going to go out and get reinfected. And it turns out, using a reasonable range of reinfection rates, it's still worth doing. So that's really important because there's a lot of policy talk around and stigma around not treating injection drug users because of the risk of reinfection, but our analysis says that that's not really really a fair criticism. And then we've got additional sensitivity analyses in process. So the trial was actually conducted before the new regimens. People may be more interested in linkage than they were at the time of the trial. The trial only talked about linkage to that first visit with the hepatitis C clinician. So the rest of the assumptions are from the literature, not from the trial. And the HIV results, as I mentioned, probably reflect a lot of resources available for HIV-infected people in New York and San Francisco, especially in those particular settings, and may not be relevant to other parts of the country or North America where those resources may not be available. So our preliminary conclusion is that doing this intervention in methadone maintenance in the US is a good thing and below our cost-effectiveness threshold. So where do we go from here? So this is my one sort of next step slide. We have several studies ongoing. The next step in this particular funded project is that we are going out into the field and finding programs that are actually doing this, substance use treatment programs, not just methadone maintenance programs. So we have a stratified sample from a survey where we're finding programs in different settings, different states, where they do or do not have Medicaid expansion, and other characteristics of the states as well, to try to find case studies. So it's a case study, it's more of a qualitative approach, but we're trying to at least choose programs that are in different settings to say, how did you do this? How were you successful? How did you get it funded? And then we're going to look and do a budget impact analysis of how they're actually funding it. And then what were the organizational aspects of this that allowed you to be successful? And I think the two relate, right? So you had some leadership issues that allowed you to find the funding somehow, even though you were in a Medicaid non-expansion state. So we're really excited about that. We're also going to do some exploratory studies of syringe exchange programs, and that I'm really excited about, as well as we're supplementing a syringe exchange survey that is currently being fielded to find out more about that, and hopefully we'll submit for a subsequent grant really to focus on syringe exchange programs. And then 2 studies have recently been, well, one not so recently and then one more recently funded, that are looking at this bundle testing. And one is a study in a couple of sites in New York that's looking at how do you implement bundle testing, what are the barriers to implementing bundle testing, and how do you create a training program for that. That's the R34. And then out of that is a large randomized trial in multiple sites where they're testing a practice coaching intervention. So the intervention is not at the patient level, it's at the site level, at the program level. So it's sort of a national center that will provide practice coaching to the programs to coach them on how to implement. And so we're going to look at the cost effectiveness of the practice coaching. So what's the cost effectiveness of creating this national center to build capability, build capacity to do this testing. So that's going to be my first cost effectiveness of a practice coaching intervention. Bottom line, HCV and HIV testing and substance use disorder treatment programs represents good value for money. Testing without effective linkage wastes money. Cost effectiveness is not cost saving. Repeat after me, cost effective is not cost saving. Economic analysis and budget impact will be a key component of implementation studies. I want to thank the research team from many places that has been working with me on these analyses, and follow us in CHERISH. Thanks.